Hello, hello. My name is Jones, and today we are looking at the third phase of peri-operative care. We are going to look at post-operative care. So, this is the third video in which we are looking at peri-operative care as an as introductory lessons to surgery and surgical nursing. Okay, so in the first lesson, we looked at pre-operative phase, which is the first phase of peri-operative care. And then in the second lesson, we looked at intra-operative care, though we concentrated much to look at emergency care. Okay, so the second phase of peri-operative care is intra-operative phase. Then the third phase is post-operative phase. So within this lesson, we're going to concentrate on post-operative interventions and activities that a nurse can do when nursing a patient with a surgical condition. Okay, so that is how we have been moving. So if you have not watched pre-operative phase and emergency pre-operative care, then I urge you to look at those two lessons before you can listen to post-operative care. Okay, so it will help you to have ideas of what was being done in the pre-operative phase, what was being done for emergency pre-operative, and what is being done also in the intra-operative phase. Okay, so this lesson strictly will be about post-operative care. So the general post-operative nursing, okay, or nursing care begins when the patient is taken from the operating theater into the nursing ward and will continue even after when the patient is discharged. The general post-operative care will begin when the patient has now been taken from theater, and it will continue up to the time the patient is discharged, because when we discharge the patient will be required to come for review. Okay, for review concerning the same surgery until patient is considered fully treated. So the focus of the nursing care plan may change from supportive to ambulative as the patient moves towards recovery. So as the patient comes from theater, there's a lot of supporting nursing care that is needed because the patient may not be able to do certain things on their own. But after the patient recover, then you might need just to assist with certain things, and patient will eventually gain independence and start doing things on their own. So from the operating theater, the patient is taken to the recovery room. From the operating table, patient is taken to the recovery room. So the recovery room becomes the first unit that the patient may be taken to immediately after the operation. Most hospitals have recovery rooms either within the operating theater department or adjacent to it. Okay, so this recovery room may be within theater, or you may have a bay just adjacent to the theater, which may act as the recovery room. Okay, in a few instances, patients may be returned directly to the ward, especially, let's say, if it was not a major surgery or local anesthesia was used and the patient is stable. So, in such instances, patient may be taken just directly to the ward. Okay, so for major surgery, patient needs first to be observed in the recovery room so that they can completely recover from surgery. Advantages of having a recovery room is that there will be constant observation that will be provided by staff experienced, okay, to do immediate post-operative care. Okay, and since we are going to have these staff who are experienced in conducting immediate post-operative care, you will find that they will not have divided attention. They will wait for a case to come and then provide that immediate post-operative care that is needed. And then the other advantage of having a recovery room is that the nearness of to the operating theater will reduce the distance that the patient has to be transported in a critical period. So the patient will just be transported to a nearby bay, okay, or nearby recovery room where they will easily be observed, unlike moving them to a ward that might be a little bit of a distance to the operating room. And if there is an emergency, okay, that may arise because of some post-op complication, it becomes very easy to return the patient to theater and correct that mistake. So the equipment necessary for emergency is also concentrated within the recovery room, making it easier to resuscitate the patient in case of any complications. And also, it works well because this is a critical period that the patient needs to be observed so that they can recover from the effect of surgery. The other advantage is that the ratio of nurse to patient um, in the recovery room is a little bit minimal as compared to the ward where it can be one nurse to 12 patients. So here you can have uh, one nurse to two or three patients within the recovery room, which makes it easier for the nurse to give total nursing care within the recovery room. The patient is going to remain in the recovery room until they have fully regained their conscious, okay, and the vital signs are within the stable range. So helps to this will help to prevent complications that may easily that may arise immediately after the operation. So any post-operative complication that may arise in few hours after operation can easily be observed and corrected if you have a recovery room. Okay, then we can now look at preparation to receive the patient. Preparation to receive the patient will be done by the wards that had sent the patient to theater. The ward where the patient is supposed to be admitted after operation. So preparation to receive the patient is done by the surgical ward where the patient will be transferred from theater. So here what we can say is that patients without complications after surgery are usually taken to the ward, like earlier indicated, and these are patients who have not shown any signs of complications. In the ward here, the post-op patient is given a special bed where they can easily, or they will be put within a special bay where they can easily be observed and where a lot of equipment are present that can be used in order to correct minor deficiencies that that may come because of operation. So the minor deficiencies like inadequate oxygenation, um, um, inability of patients to remove secretions or to remove their secretions, which compromises airway. So you find that within the emergency bay, all these things like the suction machines will be there to assist the patient, okay, and other supportive equipment to provide oxygen and also to help in breathing. Find that these will be found within the surgical wards, that is the bed where the patient is first received from theater. So the basic equipment assembled by the bedside can include the sphygmomanometer, which monitors blood pressure, stethoscope, which can help to monitor heart rate and heart function, a thermometer that may help to monitor temperature, emesis ball. You need to know that some anesthetic drugs may induce a vomiting. So the emesis ball is important to help the patient to help reduce the age of vomiting that may come because of anesthetic drugs. Okay, so you can have face flannel, recording charts, drip stands. Okay, so all these can be available, including suction apparatus, ambu bag, which can be used in resuscitating of the patient in case of inadequate oxygenation. Emergency tray will be around. Emergency tray contains the drugs that are used to resuscitate patient. Sterile syringes and needles that are supposed to be used in the same and that is in the same resuscitation of the patient. Tourniquet, spirit or alcohol swabs, okay, that he help maintain sterility and cleanliness as you are doing some procedures. Oral, pharyngeal, airway, and endotracheal tubes also supposed to be uh, are supposed to be present because they will help in dealing with the certain deficiencies that may come because of an operation. So once the operation is successfully done, the theater crew will send a word, mostly a phone call, to the ward that the operation has been conducted, and the ward nurses can go and collect the patient. So, as the nurse now assigned to go and collect the patient, they are supposed to carry with them a tray containing gloves, tongue depressor, and an emesis ball in case of patient vomiting or airway occlusion. Okay, by the tongue. So they're supposed to carry this. So there's a special tray that the nurse is supposed to carry as they are going to collect the patient from theater. So handover is important when you have now reached a theater. Okay, so we have theater nurse or recovery nurses. Okay, if you have the recovery room within theater, so we have got recovery nurses that are going to give handover of the patient of whatever transpired intraoperatively. So handover is done is done so that you are able to carry on further recovery management. So you have to ensure that the patient is breathing by observing the rising and falling of the chest. Once you have gotten the handover, you need to check on the patient so that you see that the patient that you have taken is conscious or the vitals are within normal range. So you can feel air from the patient nostrils using the back of your palm to ensure that the patient is breathing. And then you can get the handover details and include patient's name, age details, and the anesthesia that was used and the surgeon that worked on the patient. It's important to get this information because in case of any complication in the ward, the surgeon who did the operation can easily be contacted. As you correct the patient, ensure that the fluids and all blood replacements that have been done are documented within the handover notes. Analgesia given during surgery. All this needs to be documented, or you need to ensure that all theater notes or intraoperative notes have been recorded for filing within the patient's file. So completed drug chart for required post-op analgesia and antiemetics and IV fluid and collecting the drops per minute. Patient will be on a drip, so you need to ensure that the correct drops per minute in order to prevent fluid overload. So it is important as you go to theater that you get proper handover, you get properly written theater notes, or the surgeon has written notes that are going to be filed for reference. Okay, and also ensure that all tubes are patent and they are not blocked as you get the patient from theater. Then detail of drains and wounds also should be recorded. Baseline vitals and observations that were done within recovery also should be noted. Okay, when the patient can eat, to do with instructions that have been given postoperatively, you need to note. All this can be gotten from the doctor's notes that they write after conducting an operation. And any specific postoperative plan that the doctor might have ordered for implementation, you need to ensure that you read all this. Then now we can now transfer the patient from the operating theater or from the recovery room to the ward. So when a bed is used to transport or carry the patient, the, the patient is placed in a lateral or semi-prone position to keep the airway patent. If it is a cot bed, okay, or the cot rails sides should be raised to prevent falling of the patient. If the transfer is on a trolley, the dorsal recumbent position is more likely to be used for securing the patient as he is being transferred to the ward. Sufficient covers are used to ensure warmth and protection from droughts. The head is extended and an oropharyngeal airway may be in place to facilitate breathing. Along with immediate treatment orders, the nurse receiving the patient will receive a report on what has been done and receive handover of the patient's condition, inclusive of anything special of which it should be the nurse should be alert of. Okay, so now with that background of introduction to do with post-operative care, now what are the other elements that we need to be aware of that are supposed to be done post-operatively? So the other elements that we need to be aware post-operatively, apart from receiving handover or going to take the patient, the things that we have just mentioned. Now we are looking at the care of the patient now who is now in the ward. So when you are caring for the patient who has just come from theater, you need to know that there is immediate care and there is subsequent care. Just like in a pre-operative care, there is general pre-operation for general elective cases. And then there's emergency care for emergency cases. So even in post-operative care, there are these phases, okay, that we are supposed to be aware of: the immediate care and the subsequent care. Okay, so post-operative care is divided into immediate post-operative care and also subsequent continuing post-operative care. Okay, subsequent or continuing post-operative care. So in the immediate care, what is important that you are supposed to look at, because this is a critical stage through which patients might have influence of anesthesia drugs. So the ABC. So in immediate care, we concentrate so much in looking at the airway, breathing, and circulation. Then the subsequent care, we look at power. So these are the mnemonics. Power. So P is for pain management. P is for prevention of infection. P is for position. P is for psychological care. Okay. P can be protecting patient from injury. Okay, when patient comes from theater, you're supposed to put them in a bed that will protect them from injury, falls, and the like. So protecting patient from injury. Okay, so P is for all those five items that I've mentioned: pain management, prevention of infection, okay, position, psychological care, and protection of patients from injury. Then O is for observation. Okay, observations for a patient who has just come from theater goes beyond temperature, pulse, respiration, and blood pressure. It also includes observation of tubes. Observation of tubes here, I mean also IV lines that a patient may have. Also, observation of the wound site. These are very, very, very important when are dealing with a patient who has just come from theater. W is for wound care. Wound care with the right solutions. Wound care, you need to know indications for proper wound healing. Okay, so W is for wound care. Then E is for exercises. Exercises postoperatively are important in order to prevent deep vein thrombosis. Exercises are important to promote blood circulation. Exercises are important to avoid decubitus sores or bed sores. Okay, so all this is important that you need to know. E is also for environment. Okay, environment. Nurses like so much to talk about environment. So, how should the patient's environment be? Okay, so we have understood in the immediate environment the things that are supposed to be there. That is within the post-operative bed that you had prepared. Okay, so E is also for education. Education that you need to give the patient concerning surgery. Okay, so R is for rehabilitation. After surgery, for most surgeries, rehabilitation will be needed. R is for rest. Rest improves immunity. Okay, so rest is also important. Now, these are coming from the framework of Profanema, but we have put them here because they are vital in most postoperative care for the patient. When a patient is coming from theater, they have a wound that needs to be cared for. They have got an immunity that is lowered. So there are certain commonalities that are there that we need to take care of. So we are going to look first at postoperative care to do with immediate postoperative care. Then we will look at subsequent postoperative care. So, objectives of postoperative care intervention include assessing the cardiovascular, respiratory function, level of consciousness, physical abilities, and emotional status, and also promoting comfort. This is the first objective of post-operative care. Why I talk about these objectives? Objectives will help you to know what you want to achieve. So, what you want to achieve is that you don't want patients' cardiovascular and respiratory function to be compromised because it may lead to death. So you need to observe the fluids, you need to observe that there is no bleeding because these things, if they are affected, then the patient can have problems with their cardiovascular and respiratory function. The other objective of post-operative care is maintaining adequate ventilation. If, for instance, oxygenation is less than 90%, you may require to give the patient oxygen. So you have to maintain adequate ventilation by either mechanically, okay, or I would say chemically. If you are giving oxygen, then say chemically, you have to give them oxygen and the likes. Maintaining adequate circulation. Through the fluids that you are giving, you are maintaining adequate circulation. So identifying and also evaluating potential or actual complications, and also initiating immediate emergency treatment promptly as required is one of the objective of post operation. Okay, so now we move on to the other objective, which is protecting the patient from injury. The other one is maintaining optimal nutrition balance. The seventh one is preventing any possible complications. The eighth objective is ensuring quick recovery from effects of anesthesia and surgery. So now, with the objectives of post-operation enlisted, we can now talk about the immediate post-operative care. So, talking about immediate post-operative care, we can say that this is the care that the patient is given from operation time up to recovery from anesthetic effects. It involves monitoring of general level of consciousness and protection of patient's airway and prevention of shock. This care can be given either in recovery room or in theater or acute bay in the general ward. So the operating theater communicates with the ward on the pending transfer of the patient. And if there is any need for additional items or equipment to be assembled by the receiving ward. Thus, The above mentioned equipment or the equipment that we mentioned earlier are prepared and put where the patient will be admitted, usually near the nurse's station or acute bay for easier observation. Immediate post-operative care. Other items to consider. So this environment should be quiet to ensure undue stress, okay, as it may affect the patient from recovery. It should also be the acute bay should also be well lit, should be clean, and have good ventilation. Okay, so patient assessment in the immediate care. We said there should be a quick assessment of the airway, breathing, and circulation. Okay, commonly we call this the ABC. So there should be a quick assessment of ABC. This is to ascertain the effect of general anesthesia, if they are still at play or if they are posing a risk of respiratory complications. You need to note the level of consciousness on admission from theater. Okay, so now let us concentrate on some of the things that can be done to do with airway. So, assessment of whether the patient is awake enough to try to take their own breaths or if there is anything blocking the mouth or nose. So, to do with the airway, we need to rule out any blockages. Secretions or they may come from vomiting. So we need to ensure that we remove all these because they may block the airway. The other assessment should concern breathing. You need to assess respiratory rate and oxygen saturation. And for this assessment, you need to know that you have to administer supplemental oxygen via nasal catheter or oxygen mask if saturation is below 90%. Assessment of the adequacy of breathing and whether it may need to be assisted with more aggressive interventions like a bag and mask or intubation with endotracheal tube and ventilator. So you can make assessment of this to do with breathing. Then to do with circulation, the assessment of adequacy of blood pressure and determination of whether intravenous lines are needed for delivery of fluids or medication to support blood pressure. If there is bleeding that is obvious from the incision site, attempts to control it with direct pressure should be instituted by reinforcing a dressing. After you reinforce the dressing, then you can inform the surgeon about the incidents and continue observing the patient. A finger stick blood sugar or random blood sugar can also be checked to make certain that hypoglycemia does not exist for the patient. Remember, prior to surgery, patient is nailed 6 to 8 hours. Pulse oximetry should be done to monitor patient's pulse and oxygen saturation in the blood. Okay, so record as baseline temperature, pulse, respiration, and blood pressure, and monitor regularly signs of hypovolemic shock when patient comes out from theater. Then, during the unconscious period, in cases where general anesthesia was used, the patient is placed in a semi-prone or lateral position with no pillow under the head unless these positions are contraindicated by the nature of surgery. However, to do with maintenance of clear airway and adequate breathing, if spinal anesthesia was used, the patient will always be conscious, even intraoperatively. So, when we say spinal anesthesia, this is local anesthesia. So, in local anesthesia, patient does not become unconscious. So, patient is conscious throughout the surgery. The above said position after general anesthesia are used to lessen the chances of blockage of the airway by secretions and relaxed tongue and lower jaw falling back to block the pharynx. So that is why at times they do spinal anesthesia or local anesthesia because the risk of compromised airway will be reduced when you do local anesthesia, or because there's no involvement of the brain, there will be no suppression of respiratory and muscles. Okay, so the head also is hyperextended to facilitate free entry of air and expiration. So you need to hyperextend the head of the patient in order to maintain a patent airway. So the excessive secretion can also be removed by suctioning. Okay, so you can suction them with a catheter directed into the pharyngeal area. Okay, and you can be withdrawing, resuscitating just like that. You can be suctioning just like that. Okay, movements of suctioning. So if secretions are beyond the pharyngeal suctioning, then a tracheal suctioning may be done. If there is need to give oxygen, then give it whenever necessary. Excessive secretion affects oxygenation or perfusion. So, if you are giving, for instance, tracheal suctioning, it is also affecting the amount of air that is entering, okay, that is entering as the patient is trying to breathe. So, oxygen can be given as supportive measure to prevent hypoxia. If if hypoventilation persists, the concentration of blood gases will be determined, and mechanical respiratory assistance may be necessary. Okay, so an unconscious patient may aspirate vomiters. This can be prevented by turning the head sideways and cleaning the mouth and also pharynx of secretion by suctioning. This will so when you turn the head sideways, it promotes drainage, hence preventing the aspiration of vomiters and excessive secretions. In maintenance of adequate circulation, you can assess patient's skin color, blood pressure, and pulse rate. This can be done every 5 to 15 minutes, half hourly, and hourly until these are stable. So, mostly when postoperative observations are done, that is every 15 minutes for the first 1 hour, every 30 minutes for the second hour, and then every hour for the third and fourth hour. Also observe the surgical site for signs of bleeding. It's important to ensure that the surgical site is dry. If there's active bleeding, then you need to inform the surgeon and also apply pressure. Hypotension, shock, cardiac arrhythmias, and hemorrhage are common complications that may occur in the immediate postoperative period and during the next few days. Hypotension results from anesthesia reaction to drugs, cardiac arrhythmia, and inadequate ventilation, and may also result from moving the patient. So, hypotension will result from the anesthesia. Excessive loss of blood will also lead to hypotension. So, it's important that you are aware of post-op complications that may arise. Following operation, it is common for patients' blood pressure to be slightly lower than usual. Systolic pressure between 90 millimeters of mercury and below, and a pulse rate below 60 beats or above 100 beats per minute will require prompt intervention. It may be a sign, okay, for reaction by a surgical team because there might be other complications that may be arising. So the cardiac arrhythmias is also due to anesthesia or can be secondary to a cardiac surgery. Now we look at in the post-op care protection of patients from injury. The bed should have rails and be in low position to avoid accidental falls and injuries. As As a nurse, you should remain with the patient until he has fully recovered or is fully conscious. And you have to ensure that the tubes and the essential equipments are not dislodged. This is where general anesthesia was used. The patient has got tubes. So it's important to observe patient 5 to 15 minutes or every 5 to 15 minutes when they are still unconscious. This is to uh, act immediately in case there is a complication. Okay, so now we have looked at the immediate post operative care. Now we are going to look at the subsequent post operative care. Subsequent post operative care, as earlier established, this is the care when the patient is now out of danger of the things that we see immediately postoperatively. So patient is now out of danger of the expected complications that we might see immediately after the operation. So that is subsequent care. Subsequent care is care when patient is now stable from effect of surgery. So subsequent care is the care that patient receives after recovering fully from anesthesia. This type of care continues from general surgical ward up to when the patient has been discharged. So in subsequent care, when the patient is still in the ward, there will be care of drainage tubes. Okay, in some surgeries, patient may have some drainage tubes. So, to do with care of gender tubes, after putting the patient in bed comfortably, you can check in the file for the doctor's order for specific treatment, for example, oxygen, intravenous infusion, appropriate drainage system, spatial positioning, and observations. Drainage tubes that are to be connected to appropriate bottles or a suction system must receive prompt attention as they are usually clamped during transit from operating theater. If the tube is not quickly unclamped, it may become blocked or sufficient pressure will build up in the body cavity to cause serious effect. Example here I can give if gastrointestinal tubes remain clamped following gastric or duodenal surgery, there may be abdominal distension. Okay, and this may in turn cause leakage of secretion into peritoneal cavity, and for such we might even lose the patient. So it is important to look at or take care of drainage tubes. So if there is leakage of gastric or duodenal content into the peritoneal cavity, patient may have peritonitis. Okay, so peritonitis becoming now a complication of surgery. So anyway, there are appropriate treatments that can be given if there is peritonitis, but we are not encouraging missing the point of taking care of drainage so that the patient starts having this complication. Okay, so now we come to observation. Remember, post-operative care, immediate care is ABC. Subsequent care is power. These are the mnemonics that should help us. So in power, there's all observation. So an immediate check is made of respiration, okay, color of the skin, mucous membrane, okay, and also level of consciousness if patient went under general anesthesia. That is in the observation. I know in the observation, most of the time we like talking about temperature, pulse, respiration, and blood pressure. You can also monitor oxygen saturation for this. Okay, so you also monitor the drainage of the tubes. Okay, and follow the timing for observation. Quarter hourly for the first 1 hour, half hourly for the second hour, hourly for the third and fourth hour. So these are very important, or the first 4 hours is critical. So in immediate care, that is the way you're going to observe the patient. So initial observation and patient's post-operative signs will serve as an operative baseline data, which will assist the nurse in recognizing favorable and unfavorable changes in the patient's condition and the nursing measures that will need to be instituted. Cardiac arrhythmias, weak pulse, and a decrease in systolic or fluctuation in blood pressure, abnormal respiratory rate and volume, and also bleeding in the wound should be promptly reported to the surgeon. We can observe a level of consciousness, orientation, and ability to move extremities and recognize neurological problems that may arise post-operatively. Observe intravenous site for patency and infusion for correct rate and solution. Observe fluid input and urine output and record fluid balance chart. If not documented, then it's not done. So documentation becomes very important in order to prevent repetition. Observe the surgical site and wound drainage system of the patient. So you can see, apart from temperature, pulse, respiration, and blood pressure, there are a lot of things that you can observe post-operatively. Other items that we can still include on observation: if the patient is receiving oxygen, you have to be sure that the application and the flow rate is as ordered. Observe the patient for color and also temperature. Observe patient for paleness or cyanosis. Observation here in post-operative, like, can include observation of the wound, observation of the drains, observation of the urinary catheter. So when saying observation of the wound, here specifically when you're observing the wound, you're observing it for bleeding. Okay? Color and signs of infection. If there's bleeding, the stitches. So, special observation of the wound will help to know if they are primary infection or they are secondary infections, or secondary infections have arisen. So, in the observation, apart from observation of the vitals, there should be observation of the surgical wound. Where there are drains, observe drainage. Drainage, here you have to look at the rate and volume of and the volume of, for instance, let's say blood loss, so volume of blood loss. Okay, so when you are changing, for instance, pads, okay, you're changing some pads, um, you can estimate the blood loss if you remove the pads. Okay, so rate and volume of blood loss can still be observed from the drains. Okay, so in, for instance, benign prostatic hypertrophy, there will be some blood loss resulting from the ration as you put the drainages. And then there will be the change of color that should be seen to show that active bleeding has stopped. So even the color is very important. When looking at this, you need to know signs of infections when they are setting in. Then, to do with the urinary catheter, position, patency, our urine output, and also color and concentration of urine. Ruling out renal failure can be because of inadequate urine output. You have to be sure that drainage bags are hung properly and the suction machine is functioning. Okay, so away from observation and the many things that we have discussed about observation, we can now look at control of pain and promotion of comfort. So when you're promoting comfort, it's because you are reducing pain. You cannot have comfort in pain. So even when you say promote of comfort, you are necessarily looking at pain management. So in our power, P was for pain management. So in promoting pain management, you are promoting comfort. So the common discomfort operatively includes pain because of the wound, surgical wound that has been created, nausea, and nausea and vomiting coming from anesthesia. Okay, so there can also be apprehension. Psychologically, there can be apprehension. Surgical patients may experience nausea and vomiting after surgery as a result of toxic effects of anesthesia. Okay, then they can also cause they can also cause pain and anxiety, and also handling of the patient's viscera in the abdominal surgery will bring about the discomfort that the patient may experience. So you can provide assistance to the patient by offering a vomitus bowl and a mouthwash after vomiting to refresh the mouth and reduce the age of vomiting. Okay, an antiemetic may be prescribed and administered to help reduce the age of vomiting. Empty bowls promptly should be emptied, okay, and they should have an antiseptic to prevent infection. If vomiting persists beyond 24 hours, it should be reported and indicated as possible complication or indicated as complication. You can assess pain level, pain management. Okay, so when assessing pain, it's important to know location and the quality. Also, the timing, the type, and route of administration of last pain medication. Patients may have pain from the injections that are given in theater. So, location, quality, and timing is important. If you know how to open a panometer, you can open the panometer to monitor patients' pain and comfort levels. Position patients to enhance comfort and safety, check tightness of incision dressings, and provide a restful environment. An environment where a patient is easily disturbed may bring about agitation and reduce comfort levels. Administer analgesics as prescribed and assess the effectiveness of these analgesics in relieving pain. If, for instance, a patient takes alcohol, some analgesics that are used post-operatively, you might need a higher dose or you might need an alternative. For those, especially take alcohol, narcotic drugs, okay, and narcotic analgesics may not be that effective. But you still have diversional therapy as part of your nursing intervention to help divert the patient's mind from the pain that they're feeling from incision site. Just watching football, especially for males, they forget about the pain that they're having. So just giving them a magazine to read, they might reduce their mental focus on the pain. So listening to your favorite song can also help reduce pain or divert the mind from the pain that is coming from surgery. So with that mentioned, we now look at maintenance of nutrition, fluids, and electrolyte balance. Blood transfusion may be given during major surgeries. All fluids and foods are restricted during vomiting period and following abdominal operation. So when patient comes from theater after general anesthesia, there is a period of new by mouth. So patient may start having fluids, let's say after 24 hours. Okay, semi-solids after 48 hours, and then after 72 hours, they can start tolerating other meals. So it's important that you maintain nutrition, fluid, and electrolyte balance. Intravenous infusions of electrolytes and glucose solutions are given to meet patients' daily fluids since they are like new orally. Electrolytes and energy requirements also should be balanced with the intravenous fluids that you are giving. So you have opened the fluid balance chart for each fluid that you give to the patient and monitor input and the output. Psychological care. Here, for psychological care, you can help the patient become oriented by telling him that the surgery is over and the patient is back in the room. Most patients will seek some form of reassurance in the immediate post-operative period. So you need to provide reassurance that surgery was successful and the pathology has been removed. Patient also want to know how the procedure went, okay, and the progress. So this is where you explain about the successfulness of the procedure. To do psychological care, patient also need assurance that all the tubes, lines, and equipment to which they're attached are quite normal after surgery. Okay, so are quite normal to facilitate healing. Any unexpected findings or complications that have been encountered during the procedure should be discussed with the patient. Explain measures that have been put in place to relieve pain as well as for prevention of complication. Provide information to the patient and family and allow family members to visit the patient as this also provides some psychological care of some kind. Okay, so we have mentioned nutrient and fluid, but other things that we can add on nutrient and fluid is upon waking from anesthesia, patient can have a venous line, a urinary catheter, and a nasogastric tube in most abdominal incision. So they are not allowed to eat or drink immediately following surgery. So this is to prevent paralytic ills. Anesthesia affects paralysis. So if they eat, there might be paralysis of food or paralytic areas, and food will not go down and pass through and come out when it's supposed to come out. So with the new oral may take 2 to 3 days. Okay, and this is determined by listening to the abdomen with stethoscope by the surgeon and asking if patient has passed any freighters. So this will help to rule out risk areas, and it's important to ensure that after 2 to 3 days, patient has no more bowel movement, so that they can start eating orally. That way they'll be able to tolerate food. So remember, fluids are given for reaction, fluids are given for electrolyte balance. Okay, so um, we might not have fluids that have protein, the likes of advanced countries may have, but otherwise, when you're talking about nutrition after a patient is no longer new orally, protein helps to protein helps to repair on our tissues. Vitamin C improves immunity. Okay, and then the carbohydrates for energy. So those are quite important when the patient is recovering. Then when we also talk about can talk about feed diet, fiber diet to prevent constipation when patients from theater inactivity can bring about constipation. Do with nutrition. Then patients at abdominal distension, as Ada indicated, patient experience abdominal pain after surgery, includes distension of abdomen, and this is caused by gas collection following surgery. So patients following and the like so during the nausea and vomiting. So may bring about extension and then of peristalsis also leads to buildup of air. So the distension may be relieved by insertion of electrotube for a period or by a mild A&M. Promotion of normal elimination. The patient who is adequately hydrated will void immediately after 6 to 8 hours after surgery. A total urine output will be lower than fluid intake initially, and usually because of body fluids lost during surgery and due to vomiting and fluid retention. The post-operative patient may have temporal disability void because of insensitivity of the urine bladder due to distension of the abdomen. Okay, inhibition to pass urine may also be due to anesthesia or due to trauma of the urinary bladder. The patient may have a desire to void but unable because of spasms of external sphincter. Restlessness or pain, complaints of or pressure in the peak area, or presence of a palpable mass, fullness above the cyst pubis, then you can suspect urination cause of anesthesia or because of if you, let's say you are doing prostatic benign prostatic hypertrophy surgery repair can be because of a blockage. Okay, so you need to ensure that the tubes are draining well. So distension and retention of urine predisposed to urinary bladder infection. Stasis of urine leads to buildup of infection, can increase risk of formation of renal stones. So if the patient has urinary retention, then a retaining catheter is put for 2 to 3 days to avoid repeated catheterization, which can predispose the patient to urinary tract infection and pressure from a urinary bladder or from a full urinary bladder. Okay, there should be concern if the urinary output is less than 30 mils per hour, since bowels are usually empty at the time of surgery, and that food intake is rotated for 2 to 3 days following abdominal surgery. Bowel elimination is not an immediate concern. Advise the patient that delay is normal and that it is that is not harmful. Remember, patients starved 6 to 8 hours before surgery. So, and post surgery, 2 3 days, they might not start eating. So, bowel movements or there will be delayed bowel elimination. So some doctors have ordered mild laxatives such as glycerin suppositories or a small enema. Okay, small enema 2 days after surgery. Early ambulation of the patient helps also in establishing peristalsis. Okay, so status. Then within our power to do postoperative, we talk about care. Okay, remember that surgery there's a wound that has been created. So wound care is very important postoperatively. So the objective of wound care is to have the wound remain firm and uninfected, and to heal, to promote the healing of the wound with promoting the healing of the wound, and so that it also heals with a minimal scar tissue. On completion of surgery, the wound is covered by a sterile dressing. The area is inspected frequently during postoperative period for signs of drainage or bleeding. Wound care. Here we are still saying wound care. Um, you observe the wounds for any signs of infection, reinforce case of air breathing. After 2 to 3 days, the surgeon may order the dressing to be removed and the wound left exposed or covered with thin layer of gauze. The wound is left exposed to eliminate warmth and moisture, which favor infection and cause maceration of wound edges. Covering wound is also good in that dehydration retards wound healing and dressing reduces loss of moisture. Sutures are removed in 5 to 7 days, depending on the type of sutures that have been used and the rate of healing. If clips or staples have been used to close the wound, these may be removed earlier than 5 to 7 days that we have talked about. If the dressing becomes wet with serous drainage, it's reinforced by application of sterile wound pads without disturbing the initial wound dressing. Okay, so ambulation within 6 to 12 hours after major surgery, when vital signs stable and general condition is satisfactory, patient is assisted out of bed and encouraged to walk about. So in our power, E we said for education exercises, so early ambulation, particularly to do with exercises. So 6 to 8 hours of major surgery when vital signs are stable, encourage early ambulation. At first, the patient may only take few steps, but movement is increased gradually as the patient feels stronger and more secure. Early ambulation promotes return of normal physiological activities such as gastrointestinal peristalsis, and reduces instances of respiratory and cardiovascular complications post-operatively. Early ambulation is delayed when there is shock, hemorrhage, or cardiac insufficiency. Okay, then E in power we say for education. So health education mostly depends on the diagnosis and the operation that was done. General areas of education include infection prevention, the need for nutrition, just that, adherence to education, importance of personal and communal hygiene. Mostly, when we're talking about education, we talk of the mnemonic Dr. PAN. That is DRPHN. Okay, DRPHN. These are some things that we talk of in health education. D for drugs, drug adherence. R for review. Okay, R for review in health education. Okay, then P for prevention of infection. H for proper hygiene. Okay, and then N for nutrition. That is going to help promote. So DRPHN is what mostly we talk about in health education. So use of nursing care plan, you can identify the problems that the patient may have post-operatively. Okay, one of them discomfort that they have. Okay, one of them is to do with immunity, because of lost skin integrity, immunity. So you can identify those problems. Look at the drainage. Okay, but the drainage there will affect circulatory volume. So that circulatory volume and electrolyte balance can be some of the problems that you can identify post-operatively after the patient has gone theater. So there you have it. Today we were looking at post-operative care as the last lesson in our series where we had pre-operative care. Pre-operative care has pre-op care, it has operative care, it has post-op care. And then the category important begin we have discussed. Pre-operative, we have said is general care and there's emergency care. Then post-operative, there's immediate care that requires ABC and is subsequent care. Subsequent care requires us to use power as a mnemonic. So it is not each and every case that you're going to return the frameworks that we talked about. The frameworks can be different, but the ones that we have just put across will be very in your practice of nursing within the surgical team or within the surgical ward. So for me, I'm saying thank you and keep studying.